Welcome everyone to the PEAS Clinical Practice Guide for Pediatric Feeding Disorder. My name is Beverly Collison. Together with Melissa LaChapelle, the AHS Provincial Practice Lead for Nutrition Services, we have the privilege of co-chairing the PEAS Standardized Practice and Education Working Group. Today, we are really excited to introduce you to the PEAS Pediatric Feeding Disorder Clinical Practice Guide for Healthcare Professionals. It is chock-a-block with algorithms and tables and tools and forms. Thank you for joining us. Before we get started, we acknowledge the very many health professionals from across the province who devoted countless hours to support the development of this CPG that we'll be viewing so that it reflects the most current practice. With appreciation, we also recognize Rochelle Van Vliet. Rochelle was the project lead for the PEAS Clinical Practice Guide when it was being developed. The robustness of this CPG is testament to her dedication and the passion that she poured into it. If you would like a certificate of attendance for this session, please email us at peas.project@ahs.ca. You'll see the email address at the bottom of the screen. Please be advised that this presentation is being recorded in video format for AHS. The recording may be used and disclosed by AHS for educational purposes and may be further broadcast by AHS for other presentations, publications, or promotions. This may include conversion to digital format, storing, and publication on AHS webcasting technology. A couple of housekeeping items. If you have comments during the presentation, we welcome you to write them into the chat box. Please select all panelists and attendees so that everyone on the line can see them. We will also have time for dialogue and questions at the end of this session. You can use the Q&A or raise your hand feature to ask any questions. The Pediatric Feeding Disorder Clinical Practice Guide was the first deliverable of the PEAS project. For those new to PEAS, the Pediatric Eating and Swallowing, or PEAS, project is a provincial quality improvement initiative with the purpose of developing clinical pathways to standardize and improve the care of children with a pediatric feeding disorder as defined by Gaudet et al. In 2019. For this phase of the PEAS project, our target population is children in the ambulatory care setting. For this reason, PEAS has focused the resources that you will find in the CPG on outpatient and community care. That being said, you may find that many of the PEAS resources may also be applied or adapted for other care settings. This clinical practice guide is specific to pediatric feeding disorder. Pediatric feeding disorder, as shown on your screen, is defined as a disturbance in oral intake of nutrients inappropriate for age, lasting at least 2 weeks and associated with one or more of the following medical, nutritional, feeding skill, or psychosocial dysfunction, in the absence of the cognitive processes consistent with eating disorders and pattern of oral intake that is not due to lack of food or congruent with cultural norms. It is important to note that a diagnosis of pediatric feeding disorder can be made in the absence of a diagnosis of dysphagia. Just last summer, in August 2020, the U.S. Centers for Disease Control and Prevention officially approved pediatric feeding disorder as a diagnostic code to the next edition of the International Classification of Disease, that's the ICD, It's effective October 1st, 2021. This is really a remarkable first step in recognizing pediatric feeding disorder as a standalone condition, rather than a condition that in the past has been dismissed as a symptom of a different problem. PEAS is in discussions about the impact of this new ICD code locally, and the PEAS CPG will reflect changes as this ICD code is adopted internationally. Family stories about their healthcare experiences can be a powerful tool to help teach, guide, and inform strategic priorities and influence our everyday practices. Before we launch into exploring the clinical practice guide together, with pleasure, we introduce Mona Danda and her daughter, Isha. Mona is an IT project manager for AHS and one of our many Alberta families with lived experience of pediatric feeding disorder. Mona agreed to share her family's journey navigating feeding supports in Alberta, for which we are very grateful. Unfortunately, Mona can't be with us today, and Vanessa is going to share with us Mona's story that has been recorded.
And so this project is very near and dear to my heart as an IT professional and a family member. And this is my daughter, Isha. She's 8 years old now, but I'll just give you a little bit of her clinical background. Isha reached full term. She was born through emergency C-section. She was in some distress. She had congenital heart failure, respiratory issues. There was an unknown diagnosis of trisomy 21. And here she is being taken from the Sturgeon Hospital to the Royal Alec NICU by Stork, where we spent about 4 weeks in the NICU where she was tube fed. And she was also diagnosed with permanent hearing loss while we were there. And then the next slide shows you her when we came home. So we did come home, and we removed the feeding tube, and she made gains. She eventually learned to nurse and graduated to sort of dissolvable and liquefied foods. Her absolute favorite being yogurt and ice cream. But then, during our first year of her life here, feeding fell off our radar because clinicians focused on more critical factors. And we didn't really have a specialist, I guess, or we didn't know who to turn to talk about feeding. And although we always knew it was going to be a challenge because we met more families that had children with Down syndrome, and we saw some of the struggles that they faced. So, if PEAS existed 8 years ago, I would have taken it upon myself, or I could have, to learn more about feeding disorders. A lot of people would just tell us, don't worry, it'll work its way out. But, I could have maybe completed the patient questionnaire on the site to see, if I should be concerned, or is there something I could be doing? And I also believe it really would have prompted us to seek some assistance earlier than we did. The next slide shows her starting to transition to solid food. So, her transition to daycare was quite a challenge. We had to acquire an aid by ourselves, as our daycare had never had a child with special needs. She needed full support for feeding and all of her, basic life functions. So in this picture, she's actually nearly 3 years old. So she's sitting up, she's able to sit up, keep her head up at this time. And then, my solution to getting her to eat solid food was dousing everything in her favorite foods, which was ice cream and yogurt, because I knew that's what she loved and that's what enticed her. And then I also started to feed her on the floor because that's kind of where all the food ended up. We also noticed as she was feeding, going to solids, that more food was actually like on her face than in her mouth. And again, PEAS has got great information, including like specific handouts about how I could have graduated to different textures, like, minced and pureed and food ideas. So I could have utilized that at that time. And then the next slide shows her in her toddler years. We kind of started to exclude ourselves from social gatherings because it was awkward, and the way I was feeding her and how she looked was uncomfortable for me. And truly, I was just jealous of how easy it looked for all the other kids. She couldn't communicate verbally, and I'm feeling like an all-around failure at that time. So my heart sang when I saw that there was a self-care component in Peas, because during that time I neglected my self-care, and I neglected my other children. So addressing that in Peas is so wonderful. So during this time in her toddler years, oh, sorry, if you could, well, we saw a number of different SLPs. We saw, and they gave us different advice, different top tools. You'll see here, these are all like some of the tools we pursued. Sometimes I would just meet another family member that said, this spoon works, and this person's selling it in their basement. And I would drive all the way to Spruce Grove to buy this spoon. And I was just willing to do anything. And we'd have a number of different handouts from different SLPs with conflicting advice. And so that left things for us to figure out. And it was a really confusing time. And also at that time, when the SLP we had that specialized in Down syndrome was charging $180 an hour. And, we could really only afford to have 3 covered visits during that time. So my hope for future families is that Peas can be used as a single source of truth. So we can all of the information that I would need would be housed in a single location, and it would outline supplies and what funding is available to me. I just think this is going to be so much easier for families in the future. And then about when she was 4 years old, we were offered specialized services through FSCD. And then everything just went uphill from there. We had a multidisciplinary team. We had an OT, behavioral consultant, SLP and SLPA. And we actually learned about setting her up for success, proper posture, not feeding her on the floor, working on her wiggle jaw, her sensory issues around her mouth so she could feel food on her face. And then we learned about creating the right environment to get her excited to actually eat solid food and use rewards. So, she really progressed. I mean, in these pictures, she's still having ice cream, but her palate increased so much. So, our family made gains in those 3 years, but she made gains in those 3 years, but our whole family really felt so supported during that time. And then about 1.5 years ago, we lost specialized services and we transitioned her to a community school. And so now we're in a different phase. At school, she does have an OT and an SLP through Edmonton Public School Board, but we don't get to meet with them. And because she has a cognitive disability, it just takes her 3 times longer to do most things. And, so she's often presented with the choice to either eat or play with her friends. So as you can imagine, she chooses the latter. And she's usually malnutrition. Like I don't feel she gets the right nutrition during the day. She's fatigued, and they are always talking about behavioral concerns. And I think that has to do with her lack of getting proper nutrition during the day. And what I love about Peas is now for the next year, I've actually looked at Peas to look at what kind of utensils or containers can I pick up for her that might make things quicker for her. And I can access that information without a referral. And as my priorities change, I can maybe drop off looking into feeding for a week and pick it up again in 2 weeks. It just offers so much flexibility. And the last slide is just a picture of her a few months ago. And she's a really diverse plate here. And it took her 1.5 hours to eat this. And I don't think she picked up her fork and her knife at all that time, but she's made a lot of success. And as a parent, I'm so thankful to have Peas as a tool. I wish I had it 8 years ago, but I'm excited for new families. And also as an AHS IT staff of 15 years, I have never seen anything so tailored and customized to support families and not just clinicians. And I'll just end by thanking all the wonderful clinicians here for everything that you do. You are so well loved and respected. And thank you so much.
We are so grateful to Mona for sharing her beautiful Isha's journey with us. Mona's story is a testament to how deeply her experiences motivated her to help others including her remarkable advocacy through PEAS, as well as all of us on the line today. As Mona alluded to, pediatric feeding disorder affects more than 2.3 million children under the age of 5 in the US each year. Through collaborative care and the proper support, pediatric feeding disorder can be well regulated and treated. This CPG aims to provide evidence-based clinical guidance to do just that in order to enhance pediatric safety and quality of life. The PEAS CPG is based on an adaptation with permission of the New South Wales Guide, Feeding Difficulties in Children, a guide for allied health professionals, and augmented with Gaudet and colleagues' 2020 framework for pediatric feeding disorder, and then enhanced with additional literature reviews. At its core, the CPG provides information, guidance, and recommendations to support healthcare professionals in making clinical decisions about the screening, assessment, and management of children diagnosed with pediatric feeding disorder. Here's where to find the CPG on the PEAS website. On the ribbon at the top of the screen, click on For Providers. It will take you to the clinical practice guide. Click on Read More. You choose to download a PDF version of the CPG or use the menu on the left to navigate through the interactive online content. Check out the CPG Quick Reference. With one click, it takes you to an inventory of 11 figures and 28 tables. When you click on How to Use this guide, you will see this Pediatric Feeding Care Cycle, a figure that will recur throughout the CPG. It represents the assessment and management of pediatric feeding disorder in children as an ongoing cyclical process. The inner quadrants depict the 4 distinct but interrelated steps in the pediatric feeding care cycle: assessment and reassessment, diagnosis and goal setting, management, monitoring and evaluation, and then again, assessment and reassessment. Details regarding the necessary actions are recommended in each quadrant. The outer ring identifies the components of the guide that relate to the steps. The conceptual frameworks that anchor this clinical practice guide are based on a number of consensus definitions. Early on, during the development of the PEAS clinical practice guide, the multidisciplinary working group reached consensus on definitions for typical eating, feeding, and swallowing, as well as pediatric feeding disorder and dysphagia. You can find these definitions in the preamble of the clinical practice guide. Likewise, consensus was reached on the scope of the CPG and a definition of complex care. This guide applies to infants, children, and youth with pediatric feeding disorder from birth to 18 years of age. It recognizes that understanding and agreement on the concept of complex care needs is at times confusing. You will see in the model adopted by PEAS shows the relationships between family needs, chronic conditions, functional limitations, and healthcare use as they relate to the complex care needs of the child and family, and how this in turn relates to pediatric feeding disorder complex and non-complex needs. Feeding is a reciprocal process that depends on the abilities and characteristics of both the parent and the infant and child. Focus on feeding relationship and the achievable goal of helping the child learn eating skills and positive eating behaviors sets the stage to establish a smooth and pleasant feeding relationship that is appropriate for each child's developmental stage, nutritional needs, and neuromuscular development. This relational approach that includes responsive feeding, a responsive feeding environment, and responsive feeding intervention is woven throughout the entire clinical practice guide. As we work through the clinical practice guide, the first section is focused on screening. Screening is a strategy used for the purpose of investigation and is positioned alongside the pediatric feeding care cycle as an optional precursor to assessment and management. Feeding screening may identify the risk of a pediatric feeding disorder so that infants, children, and youth may be referred for a comprehensive assessment. Screening is not diagnostic, and outcomes do not provide information about feeding difficulty severity or best management. For screening, PEAS recommends the Feeding Matters Infant and Child Feeding Questionnaire. This remarkable online tool is available for both families and healthcare providers. It leads families and health professionals through a series of questions that use smart logic to arrive at a risk statement for pediatric feeding disorder. Importantly, as families and healthcare providers work through the questions, each provides education about typical and atypical feeding and eating development. This questionnaire serves as a robust platform to start a conversation with families' care providers, such as their family physician. After completing the Feeding Matters Infant and Child Feeding Questionnaire, families can return to the PEAS website and click on Find Services to locate services in Alberta. The next time you explore the screening questionnaire, we encourage you to also check out a recently published article in the Journal of Pediatrics that describes the psychometric properties of this publication. You can find that on the PEAS website under the Community of Practice. The next section of the clinical practice guide is the assessment section. Assessment is the foundation for intervention of every care plan. Assessment and reassessment of feeding difficulties includes working through a number of assessment questions, considering each of the 4 health domains specified by Godet and colleagues in their framework, and identifying where there may be dysfunction and documenting. This is depicted in the pediatric feeding care cycle in black. An initial assessment of feeding includes considerations within the medical, nutritional, feeding skill, and psychosocial health domains. Due to interactions across these domains, impairment in one domain can lead to dysfunction in any of the others. To guide a thorough feeding assessment, PEAS identifies 5 questions to be answered within the 4 health domains nestled within each question. Number 1, is the current method of feeding safe? Number 2, is feeding adequate? Question 3, is feeding a positive experience for child and parent? Question 4, is feeding appropriate for the child's developmental capacity? And question 5, is feeding efficient? These 5 questions are listed in order of priority to identify, diagnose, and address feeding problems. The questions and considerations included in the CPG are aimed at supporting a thorough feeding assessment rather than being used as a checklist. Please see the CPG for more detailed considerations for each question and each domain. A clinical evaluation of swallowing is the first step in determining the presence or absence of a swallowing disorder. The evaluation addresses the swallowing-based activities of eating, drinking, and secretion management, and may include oral hygiene and management of oral medications. In order to guide a thorough swallowing assessment, PEAS identifies one primary question, which encompasses 3 dynamic assessment elements. Is swallowing safe? That is, are there signs and symptoms of decreased airway protection? Can physiological and respiratory stability improve safe oral feeding? And can compensatory strategies or rehabilitation interventions or diet modifications improve safe oral feeding? Instrumental evaluation is conducted following a clinical evaluation when further information is needed to determine the nature of the swallowing disorder. Instrumental evaluation can also help to determine if swallowing safety can be improved by modifying food textures, liquid consistencies, or positioning. The 2 most commonly used instrumental evaluations of swallowing for the pediatric population are video fluoroscope swallowing study and fiber optic endoscopic evaluation of swallowing. VFSS and FEES exams can be complementary and augmentative. Both tests provide information about modifications that can be made to enhance swallow safety and allow an infant or child to continue eating by mouth. Determining the most appropriate procedure to use depends on what needs to be visualized and which procedure will be best tolerated by the child. Within the CPG, you will see tables such as those on your screen and will find indications and contraindications of both of these assessments as well as their respective advantages and disadvantages. I will now turn it over to Melissa, who will walk us through the management sections of the CPG.
Thanks, Beverly. I hope to give you a high-level overview of the management section, just recognizing that we're going to highlight some of the areas where robust discussion occurred in relation to practice change, but unfortunately, we're not going to get into all the nitty-gritty detail that we've got in the CPG. So as clinicians, once we have assessed and identified a pediatric feeding disorder, we can facilitate goal setting to address concerns of the child and family. Interventions to achieve therapy goals will be more successful when planned in collaboration with children and caregivers. And management of a pediatric feeding disorder is multifaceted, as we've learned from assessment and as we'll see going through the management section, and should be grounded in evidence-based practice. Oral interventions should always consider patient safety as a first priority before engaging in oral feeding. Medical stability, facilitating safe swallowing, optimizing nutrition, appropriate seating and positioning, feeding skill development, feeding environments and routine, sensory processing considerations, and oral hygiene all play an important role in the management of a pediatric feeding disorder, which we heard clearly from Mona's story today. Medical stability. So management of all medical diagnoses is crucial to the success of other interventions. If feeds are initiated prematurely, a pediatric feeding disorder can be exacerbated. Oral feeding progress can change from feed to feed and day to day, which requires routine monitoring and reassessment as depicted in the pediatric feeding care cycle shown earlier. In children who have been medically unstable or non-oral for a considerable period of time, confirmation of medical stability by a physician for appropriate initiation of oral feeds is recommended. We have listed a number of considerations in the CPG that suggest medical stability, which are listed here. Any observations that an infant or child is at risk or may be aspirating should be referred for further assessment. Strategies to support safe swallowing function should focus and prioritize feeding safety. Intake adequacy, facilitating a positive feeding experience, supporting development, and feed efficiency certainly come into play once feeding safety has been established. Management following the identification of dysphagia should involve a team approach, and reassessment is recommended whenever a child has had a significant change to their health, development, medical status, or after airway surgery or extubation. Dysphagia intervention can include compensation strategies and rehabilitation techniques, or a combination. And you can anticipate an update to this section in a future revision of the CPG in the near future. Several management strategies are presented in the CPG. Pacing assists the infant to coordinate their suck, swallow, breathe cycle and allows reestablishment of a normal respiration pattern. Methods of bolus delivery, including nipples, cups, straws, and spoons, can facilitate normal feeding patterns and improve intake. Appendix 6 and the equipment list offer a wealth of information for providers and families on a variety of the equipment available. Appendix 4 offers providers additional information on nipple flow rates. Children with dysphagia should be assessed for safety before progressing to more challenging food textures, and children should be offered food textures in line with their developmental capacity to support adequate nutrition intake and hydration. The working group highlighted the need for a provider reference for thickener selection and recommendations for use, which can be found in Table 9. All children with a pediatric feeding disorder benefit from a nutrition assessment, as they are at greater risk of malnutrition and nutrition deficiencies. Oral nutrition support strategies to optimize food, fluid, and nutrient intake are often needed to support adequate growth and meet nutrition needs for optimal health. Strategies may vary based on the child's age, medical condition, current skill set, psychosocial factors, and current intake. We also want to reflect the individual taste, culture, budget, and lifestyle of the child and family. In the CPG, you'll find recommendations for breastfed and formula-fed infants and strategies to support children of all ages. We dive into supporting a healthy meal pattern, addressing limited food variety, and food texture progression. If oral nutrition support is ineffective, enteral nutrition support may be considered as an additional or alternative therapeutic management strategy. In the CPG, you'll find multiple useful tools such as this algorithm to support clinical decision-making. In this particular algorithm, the healthcare team first assesses whether the child is safe for any oral intake. And then we would consider our options to optimize oral nutrition support, such as a high-calorie protein diet, texture modification, and/or thick fluids, oral nutrition supplements, and other strategies. And we have also included some suggested monitoring for reassessment of oral intake. If the child is not safe for oral intake, we would then refer to the enteral section of the CPG to support decision-making with the family related to feeding route, tube type, feeding regimen, and so forth. Sometimes a combination of oral and enteral feeds is needed to support the child to grow and improve their health status, which in turn may facilitate safer swallowing and feeding skill progression. In the CPG, we have outlined when enteral feeds should be considered, focusing on airway protection, intestinal function, growth, and nutrition adequacy. Appropriate positioning of the infant or child is essential for effective, efficient, and safe feeding for suck, swallow, breathe coordination. Positioning intervention will need to be provided to those children who are disorganized, require support to maintain a midline position, and may not have achieved or will not achieve functional sitting. Guidance on the proper positioning for breast and bottle-fed infants, young children, introduction of solids, use of high chairs and boosters, as well as for those with significant postural needs are all included in the CPG. And Table 10 offers a beautiful pictorial of postural needs and some of the options available. Safe feeding may be facilitated by commercially available or specialized equipment, for which more detail can also be found in the CPG. Facilitating feeding as a neurodevelopmental skill and relational process has been emphasized in the CPG, as Beverly mentioned earlier. Children with delayed or disordered oral reflexes will need individualized treatment techniques to facilitate oral motor skills. Strategies to support facilitating first tastes, breastfeeding, bottle feeding, and provision of solids are cited. The Standardized Practice and Education Working Group has developed a number of family education materials to support skill development, which can be found on the website. And some examples include new handouts on facilitating first tastes and introducing new foods to your child. Additional handouts on food ideas by color, flavor, and texture, as well as food play and new food step-by-step are now available for multidisciplinary use. I think that we can all appreciate that mealtime is not just for eating, but it's a time for relationship building, exploring food, learning mealtime manners, and developing social skills. A predictable mealtime routine and environment can help a child learn the difference between hunger and satiation and may help with self-regulation. We want to support parents to observe their child's behaviors, reactions, and communications during mealtimes. A child's ability to participate fully in the mealtime routine can be influenced by a range of factors, including the physical and sensory environments. And supporting a positive feeding relationship with positive mealtime interactions really starts with cue recognition, supporting oral motor development, providing feedback on the child's efforts and successes, limiting the use of rewards, and avoidance of force feeding. And so in our management, parents should be encouraged to use the division of responsibility to trust their child's appetite, offer child appropriate choices, and provide foods that are in keeping with their child's sensory preferences, as well as oral motor capabilities. Each child has unique sensory processing needs and regulation abilities, and how a child responds to sensory information during mealtimes may impact their feeding development and the mealtime experience. Recommendations need to match assessment findings to enable the child to regulate and participate in mealtimes. And achieving a calm and alert state is typically a first step. The CPG provides strategies for food play, steps to discovery, oral desensitization, preparation for meals, and supporting mealtime routines and environments, which also supports the sensory preferences of the child. As we switch gears towards enteral feeding management, I do want to acknowledge the importance of oral hygiene and the dental health section of the CPG. As health professionals, we all have a role to promote good oral hygiene and identify conditions that may negatively impact feeding. And I do think it's fitting to talk about it here as we're transitioning to oral or from oral to enteral feeding, because it really does apply to both areas. And so as we move into the enteral feeding section, there are a number of sections for enteral feeding management that we'll not have time to review today. So I do encourage you to visit the website and review the many sections and appendices. We do have key messages included and really want to emphasize the importance of the interdisciplinary team and the role that family plays in decision-making and defining goals to ensure that quality, quantity, and duration of tube feeding are considered, and recognition that enteral feeding is a process that requires ongoing assessment to support tolerance, intake progression, and weaning when appropriate. So I will focus on a few key areas where provincial discussion has occurred and leads us to consider a change in practice. When oral feeding is no longer safe, possible, or adequate, Collaborative decision-making between the interdisciplinary team and family is recommended to determine the optimal feeding route, type, and duration of enteral feeding. The working group collaborated with physicians to create this decision-making tree, which emphasizes that nasoenteric tubes are intended to be temporary. Although controversial, research suggests that children have a better feeding-related outcome when we are cognizant of how long they've had their tube. Consideration of gastrostomy insertion is highly recommended when enteral feeding is expected to extend beyond 4 to 12 weeks. As there are risks to both long-term nasoenteric use and gastrostomy tube insertion, it is essential to consider the child's medical needs, overall health, ability to safely consume oral intake, and recent progress with feeding skills. Physicians and the interdisciplinary team should provide information and guidance to parents and children as appropriate early in the treatment process to assist and support their decision-making. Together with caregivers, we aim to determine the best option for the child in the short term and the long term as applicable. During the development of the CPG, literature review and consultation with both home nutrition support programs occurred to develop provincial feeding pump criteria. These criteria apply to the provision of pumps, and exceptions would require both medical and managerial consultation. The goal is to be family-centered, but also to recognize the significant costs for the home nutrition programs in directly supplying pumps to families who may want them but not medically require them. Families can still source feeding pumps and fund privately outside the provincial criteria listed here, and we're currently working to update this table to add a bit of clarity given our discussions with the home nutrition support programs. Monitoring enteral feeding should be child-specific based on age, disease, severity of illness, degree of malnutrition, and metabolic stress. The American Society for Parenteral and Enteral Nutrition recommends that enteral feeding monitoring in the ambulatory care environment occur quarterly and include a physical exam, medication review, growth evaluation, a review of the feeding type, delivery, and tolerance, as well as an assessment of oral feeding readiness and/or progression. And as we monitor and follow up with our families, consideration for both short and long-term feeding goals should help guide enteral feeding adjustments and that monitoring frequency. Transitioning from enteral to oral feeding should be considered from the time enteral feeds are initiated. Setting a clear platform from the outset prevents enteral tubes from being used longer than required. Supporting safe intake starts with supporting eating skills, and this really circles us back to an assessment of readiness for oral intake with a safe swallow. And from there, we can collaboratively set achievable goals and consider the oral management strategies we've already touched on today. The approach to weaning enteral feeds will be different for each child. There are various tube weaning programs cited in the literature, which suggests that appropriate support and monitoring, successful reduction or complete weaning from tube feeds is possible for certain children. There is no consensus on the ideal model for weaning, as this is child-specific, but in our literature review, we did find that the GRAS model or various adaptations of its principles was frequently cited and proposes several steps to weaning that encompass hunger provocation, supporting eating skills, exposure to food, reduction of stress, acknowledging and responding to the child's cues, and avoidance of force feeding. At each stage of the transition process, it's important to identify a limited number of achievable, developmentally appropriate, and measurable goals. Permanent removal of a feeding tube may be considered when the child is clinically stable, has safe and adequate oral intake, and can take essential medications orally. And it's also important that future healthcare needs will not impact the child's ability to meet nutrition requirements, and that caregivers have a clear understanding of implications for tube removal including risks of reinsertion. I would now like to welcome Beverly back to walk us through the monitoring and evaluation section.
Thanks, Melissa. Okay, let's take stock. We have now walked through the screening, assessment, and oral and enteral management sections of the Pediatric Feeding Disorder CPG. 2 more sections round out the CPG. The penultimate section is monitoring and evaluation. The purpose of monitoring and evaluation is to measure the amount of progress made for the interventions and determine whether the related goals or expected outcomes are being met. This is depicted in the pediatric feeding care cycle in black. Health professionals on the line today recognize that the time frame and frequency of monitoring evaluation will be family dependent. For instance, for children with more acute issues, follow-up may occur more frequently, whereas children with a stable feeding profile may be seen less frequently. And we are at the final section of the CPG, transition. Children with pediatric feeding disorder will experience multiple transition points throughout their lives. An interdisciplinary and collaborative approach between the interdisciplinary team and the child and family is needed to provide adequate support and to ensure that safe, successful transitions occur from hospital to home, pediatric to adult services, and discharge from eating, feeding, swallowing programs entirely. Within the CPG, you will find many tools to support family awareness of the many possible transitions. For instance, one tool specifically created for transitions is the Oral Feeding Care Plan. The Oral Feeding Care Plan is an essential part of communicating and implementing safe and successful strategies across multiple care settings, such as perhaps grandparents' home, daycare, and school. A feeding care plan is also a useful means for documenting interventions that may also require extra caution and attention, such as those related to aspiration risk or allergies. Look for this tool on the PEAS website. Similarly, an enteral feeding care plan serves the same function as the oral feeding care plan we just reviewed. Presently, the Standardized Practice and Education Working Group and Nutrition and Food Services are working through the processes involved in developing a PEAS provincial form. Coming soon. We have reached the last page of the clinical practice guide. Thank you sincerely for joining us on this walkthrough. We hope that you have found this exploration informative. We encourage you to watch the last of the 3 PEAS presentations offered this autumn that provides an overview of collaborative practice tools for healthcare providers. Mark your calendars for November 5th from 2 to 3. If you have questions or comments, suggestions or requests, please email PEAS or fill out this contact form on the website. Please also consider subscribing to the PEAS news and events. Don't forget to join your colleagues in the PEAS community of practice. As we wrap today's presentation, we wish to share and celebrate some of Isha's successes and acknowledge the key roles you play in similar victories. As we move into our question and answer period, we would like to once again extend our thanks to all of the many health professionals across the province who not only contributed to the working group, but also supported the development of this CPG. We will now turn it over to Vanessa Stenke, the PEAS Provincial Project Leader, to moderate questions. You can use the Q&A or raise your hand feature to ask questions. Thank you.
Awesome. Thanks so much, Bev and Melissa. We just wanted to provide an opportunity now for people to ask questions. So as Bev said, you're welcome to type it into the Q&A at the bottom of your screen, or if you would like to raise your hand, I'm happy to take you off of mute and you can just verbally express your question. We'll just wait and take a bit of time to make sure that people have an opportunity to ask questions if they have them. And I'll just quickly mention that if you could take them a moment also to fill out our survey. Here, I'll just flip this slide over. It'll pop up on your screen as you exit the meeting, as well as, oh, and I see a question, as well as we'll email it out to you. So Dana asked, is there a figure or table that community therapists can use to help guide referrals for complex children and families that need more medical support? So we'll just answer that one on screen.
That's a great question. Thank you, Dana. One of the working groups of PEAS is the navigation working group. And the PEAS website provides guidance on where to seek support for children with all levels of needs. And it looks like Vanessa's popping that up onto the screen for us.
Yeah, so Dana, you can go to the PEAS website, peas.ahs.ca, and then at the top here, click on Find Services. And then we have a number of different services that provide EFS support, but within AHS, we've listed them here. So click on AHS Eating, Feeding, Swallowing Services. And then depending on the zone that you live in, we've listed all of them here. So I live in the Edmonton zone, I'll just click on that one. But you can just see that we've also linked the Alberta Referral Directory profile, which often has information around how to refer in, what the criteria are, and then also other specialty clinics here for some more complex needs as well. And Calgary Zone is very similar, so just feel free to peruse that. I hope that answers your question, Dana. Any other thoughts or questions from folks on the line?
We have a quiet group today.
Yeah, really great turnout. Okay, fabulous. Thanks so much, Dana. And yeah, Falak, we will get those certificates of attendance to people who request them. I'm just going to wait until we have the last of the series of 3 next week, and then we can just email them out as a bundle, but we are definitely keeping track of that. So thanks. Any other questions or thoughts? Okay, I will turn it back over to Beverly, and I'll put that survey link in the chat window too if anyone wants to use that.
Thanks, Vanessa. Melissa LaChapelle and I, as co-chairs of the Standardized Practice and Education Working Group, again acknowledge the hours, the days, the weeks that went into developing this clinical practice guide by many that are on the line today. As well, we thank you for spending this last hour with us. And we will end by asking you to please take a few minutes to complete the PEAS survey. Thank you very much.